Hello and welcome to another live broadcast with MedStar Health. My name is McCarron Carter. So May is Melanoma and Skin Cancer Awareness Month, a time dedicated to raising awareness about the various forms of skin cancer, the most common cancer in the United States, affecting an estimated 1 in 5 Americans during their lifetimes. It's also highly treatable if detected early and treated properly. So that's why it's important to understand the risk factors, symptoms, diagnoses, and treatment options for the disease. So if you have any questions during this Facebook Live, please share those in the comments below. We'll take some time to answer those as well. And for more information or to schedule an appointment with us, please visit medstarhealth.org/cancer. Before we get started with some of our questions, let's welcome our panel of experts here. We have medical oncologist, Dr. Geoffrey Gibney, surgical oncologist, Dr. Edward McCarron, and dermatologist and Mohs surgeon, Dr. Deng. So before we get started with the questions again, I want to take some time for you guys to introduce yourselves to our viewers and share a little bit about what you do here at MedStar Health. I'll start with Dr. Gibney.
Thank you, Majan, and thank you for organizing this lovely event. I'm Jeff Gibney. I'm a medical oncologist and faculty at Georgetown University, practice in the melanoma program here, taking care of patients with more advanced skin cancers, as well as participating in research and education with training our teams here. And I work very closely with our colleagues across the MedStar network, including Dr. Deng and Dr. McCarron, who's here today.
That's great. Thank you, and welcome again. Dr. McCarron.
Hi, yes. So I'm a surgical oncologist, and I've been working at MedStar Franklin Square for about 20 years now. From the day I started, I've been working on melanoma patients, primarily working through the Maryland Melanoma Center. And I've seen so many advances over the years that it's been an incredible run, and it's a pleasure to participate in today's Facebook Live event. And hopefully we can make a positive impact by today's session.
Absolutely. Thanks again for your time. And last but not least, Dr. Deng.
Thank you so much for having me here. So my name is Min Deng, and I'm a board certified dermatologist and fellowship trained Mohs surgeon. I also specialize in cutaneous oncology, a lot of basal cell squamous cells, early stage melanomas. I really focus my clinics on the diagnosis, screening, and the treatment as well of many of these diseases. But I work very closely with my colleagues in Surg Onc and Med Onc and Rad Onc. So it's a pleasure to be here today.
Thank you again, and thank you all for your time today. So let's start with talking about the risk factors for skin cancer and melanoma. So Dr. Gibney, could you share what is skin cancer, what is melanoma, and what's the difference between the two?
Sure. So we know that cancer can arise from the skin, and there's different types of cells within the skin, and these can produce or lead to different types of skin cancers. When we talk about melanoma, these are derived or evolved from cells called melanocytes. Those are the pigmented cells in the skin. And as those cells grow and divide, sometimes that growth pattern becomes abnormal and out of control. And those cells biologically change and start becoming more invasive and growing in a manner that isn't what the original purpose of it was for our bodies. These then can form into tumors that are now more aggressive, as we would call a melanoma. The other types of skin cancers arise from other cell types. So those would be, for example, the keratinocytes. These are a different cell in the skin. And if those start growing abnormally and invading the surrounding structures, those can develop into basal cell carcinoma or squamous cell carcinoma. There are other cell types in the skins that can lead to more rare skin type cancers. And we have to be aware that the range of melanoma and non-melanoma skin cancers is quite wide. And sometimes these have much different appearances. Even the same type of skin cancer, a basal cell, can look differently. So this is where it becomes very important working with our colleagues in dermatology. The key difference I would say between melanoma and some of the other skin cancers, melanoma is a very aggressive, potentially more life-threatening cancer than some of the other skin cancers like basal cell and squamous cell. So we know the mortality rates for melanoma are much higher, and the surgical interventions tend to be a bit more aggressive because we have to ensure that there's adequate removal of the tumor so that we can lower the risk of recurrence. Compared to some of the other types of skin cancers like basal cell and squamous cell, the risk of recurrence is lower, so the management is in parallel with that, where it tends to be require less surgery or less risk of spread.
All right, thank you very much for explaining all of that. Dr. McCarron, could you share what are the risk factors for skin cancer and melanoma?
Michelle, I would say that the number one risk factor for skin cancer is sun exposure. We know that ultraviolet rays from the sun or any source, even like a tanning bed, can damage skin cells and cause them to convert over into cancer cells and cause abnormal growths. Your skin type also plays a big role. We all know those folks that are sensitive to the sun and get a sunburn very easily. So if you have fair skin, light hair, blue-green eyes, I mean, you're going to be at risk for sun exposure and sunburns. Also, another risk factor would be if you have multiple moles on your skin. So we know that people with several moles on their skin can be at risk for melanoma. And we refer to that almost as like there's a genetic problem with that called dysplastic nevus syndrome. And those are people that will have like over 100 moles on their back. So that's a risk factor. And then, of course, there's always, if you have a family member with melanoma, almost 1 in 10 melanoma patients will have a first-degree relative with melanoma. So family history plays a role. Other things would be if you have a weakened immune system, those patients can also tend to develop skin cancers.
Thank you for sharing that. And I think you segued right to my next question about people who are at a higher risk. Could you share a little bit more about that and explain the reasons why, and if people who have darker skin tones are less likely to get the disease?
I think that's a great question because melanoma will impact all races and all types of skin color. So the issue with a person with darker skin is that they're not really aware that they're at risk for this diagnosis, and then they can tend to ignore things and be diagnosed much later. The idea would be is that a white person would be about 20 times more likely to get melanoma than a black person. If you were going to put it into numbers, like in the United States, I would say about 1 in 40 white people would be at risk for melanoma. About 1 in 1,000 Black people would be at risk. And if you look at the Hispanic population, it would be about 1 in 70. So that's kind of how you can think about gauging the risk that people have with melanoma. But I want to be clear that it can definitely hit all races and all skin colors.
Thank you. That's a very important point from personal experience. I didn't realize the importance of reapplying sunscreen at a younger age, and very rarely got sunburns, but it's definitely important for people with darker skin tones to be more aware of that. So thank you for explaining that. Could you share how we can reduce our risk for getting melanoma or skin cancer, Dr. McCarron?
Oh, sure. I think there have been terrific public service messages about reducing risk of skin cancer and melanoma. And it always comes to mind. It's in my head almost all the time. like be sun smart, right? Like that's the big thing that people say. And it's like the 5 S's. Like what do they say? Slip, slop, slap, slide, seek, right? Everybody knows those. So you have to slip on your shirt, slop on your sunscreen, slide on your sunglasses, seek the shade, and just be sun smart. So What I try to do with my own family is we try to avoid blistering sunburns because I come from a family that loves the beach. We love going to the pool. We love going to the ocean. But if I can get the family through a summer without a blistering sunburn, then I feel like I've done my job. The other thing is that people should be aware of a lot of the myths that exist around melanoma. So using a tanning bed and getting a protective tan is not helpful. So you know, I always kind of have in my head also that like a tan skin would be damaged skin. And so again, I think the ideal thing is be sun smart and avoid overexposure to sun or you know, tanning beds and those things.
All right, thank you, Dr. McCarron. So now that we've talked about the risk factors, let's talk about diagnosis. I want to turn to Dr. Deng. Could you share what are the signs and symptoms for melanoma and skin cancer?
Yeah, thank you so much. So I think it's great that you're separating melanoma away from skin cancers because they present very differently. And I know a lot of what we've described so far has been around melanomas, kind of moles. But maybe I should start with skin cancer in general, because annually there are millions of basal cells and squamous cells. And so to put that into perspective, annually in the United States, we have about 200,000 cases of melanoma estimates. So just by numbers, people are much more likely to either experience or know someone who has a basal cell or squamous cell compared to melanoma, even though it's extremely important that you know what to look for both. So I think for skin cancer in general, the basal cells and squamous cells, a lot of people are attuned to look for the dark moles, but you're really looking for something that may be skin colored, maybe a little pink. I've sometimes had people mistake them for pimples, but the key here is it's like a pimple that never goes away, or it bleeds occasionally, or it's starting to get a little bit bigger. So it is not necessarily going to be dark or black. It can be pink, and sometimes it's just it hurts or it bleeds. So I would say, you know, if you have especially a family history or a personal history, and there's a spot that just seems like it's changing in front of your eyes, even if it's not black or brown, please get that evaluated. I also think it's really important to highlight one additional presentation of skin cancer, squamous cell cancers, that's not thought of as much, which is the development of squamous cell cancers in chronic wounds. So these are the patients with like diabetic foot ulcers or you know, traumatic wounds that have maybe not healed for years. And even though those may have started out non-cancerous, over time, these chronic wounds can fester and can turn into squamous cell cancer. So that's another category of cancers that is sometimes not as easily recognized because individuals say, oh, I just stubbed my toe. I know this is traumatic. It's not cancerous. But over time, if it's been 10 years, 5 years, and it's not healing, please, you know, certainly you don't even have to wait that long. But certainly if it's not healing and it's, you know, continuing to fester, please get it evaluated, because even if it wasn't cancerous to start out with, it can turn cancerous over time. So that's kind of skin cancer. And then for melanomas, we look for kind of, you know, the bad moles, quote unquote. And we use the A, B, C, Ds, and E's to kind of screen for these. And it's very easy to do yourself. So what you're looking for are the moles that may be A, are asymmetric. So most moles are, you know, kind of round or oval. You can kind of, you know, they're somewhat symmetric. B stands for irregular borders. So some of the melanomas I've diagnosed have been triangular shaped. One of them was the Batman logo shaped. You know, so something that's out of the ordinary, definitely a different shape. Take a look at it. C stands for color variation. So most of our moles are one or maybe a shade of brown, you know, like one color, maybe with a slight variation in tone. But if you're starting to see brown and black and pink and gray, the more colors there are in there, the more worried we become. D stands for diameter, and I don't love D, but I'm still going to, present it to our viewers. So The idea behind D is that you're more likely to develop melanomas from larger moles. But the reality is that melanomas can start teeny tiny, they can start small. So I don't love D because melanomas can be both small and large. And E is probably the most important thing to look for, which is evolution. So if you notice a mole that's starting to change color, starting to change shapes, maybe itching, becoming symptomatic, please have that evaluated. So A, B, C, D, and E, asymmetry, irregular borders, color variation, diameter, I don't love that one, and then evolution.
Thank you very much. That's very important. It's given me a lot to think about. I probably need to set up a dermatologist appointment, come to think of it. So thank you very much, Dr. Deng. Could we talk now about how melanoma is diagnosed and also how skin cancer is diagnosed?
Yeah, I think, it is very helpful to kind of be aware of your own personal risk factors. So kind of what Dr. McCarron already mentioned, if you know that you have a strong family history, or if you know that, you went to a lot of tanning booths when you were younger, you had a lot of, you like to go to the beach, or you have a changing mole, please, again, kind of seek a dermatologist for your skin check. But essentially, once patients come to our clinic, we look at their skin. So it's not uncommon to have patients ungown, or to reveal parts of their bodies so that we can actually check the skin. So that's called a skin screening. And then typically, if we find something that we think is suspicious, we will recommend a biopsy. A biopsy is fairly minimal of a procedure. We do numb up the area, we take a little piece and we test it in the lab. So we look at it under the microscope. And that's really the gold standard for diagnosing skin cancers, to have the clinical suspicion, but then have that confirmation by checking it under the microscope and confirming that it's a skin cancer.
All right, thank you very much. I think this perfectly goes into my next question. You mentioned screening. Is there are there certain diagnostic tools that are more effective than others? Could you share more about all of the diagnostic tools that are available for screening for melanoma and skin cancer?
Yeah, I still think the best diagnostic tool is a good, clinical exam by someone who maybe is very comfortable and experienced with doing skin checks. That's still one of the best diagnostic tools. There are things that dermatologists will use, or other physicians may use, to help us with the skin screening. So we have a little tool that helps us, called a dermatoscope, that helps us filter light in a certain way so we can see the features of your moles a little bit more clearly. There are some other innovations in the research realm, with some, kind of sticker genetic tests. But I would say that, still the gold standard is ultimately a biopsy, to make sure that we are, accurate in our diagnosis.
All right, thank you very much. And how does one know that they need to be screened? Perhaps they do their skin checks, they, see a suspicious mole. What do they need to do? How do they know this is when I need to go to the doctor?
Yeah, certainly. So if something is bleeding, if something is itching, hurting you, if something is changing before your eyes, if you have a mole that looks different from all of your other moles, so we call that the duckling sign, I would get that checked. And some of the less common presentations that people may not be aware of, if you notice a dark band around your nails, that's something to be aware of. A lot of people kind of dismiss that. Or if you notice, changes in your nails, that's sometimes something that's underdiagnosed. And again, if you have a scar or a wound that's not healing, it's been a while, I would have someone look at that as well, and be suspicious for a skin cancer.
Thank you very much, Dr. Deng. Very important information. At this time, I want to pause and welcome our viewers again. Thank you very much for tuning in. In honor of Melanoma and Skin Cancer Awareness Month, we're raising awareness about the risk factors, symptoms, diagnosis, and other treatment options that are available for the disease. I'm here with several of our experts. We have Dr. Geoffrey Gibney, medical oncologist. We have surgical oncologist, Dr. Edward McCarron, and we have dermatologist and Mohs surgeon, Dr. Deng. We have much more to talk about, but if you have any questions, please share those in the comments. We'd like to answer those as well during this time. And if you'd like any more information about skin cancer and melanoma, please visit our website at medstarhealth.org/cancer. All right. So at this time, we've talked about the risk factors. We talked about diagnosis. Right now, I want to direct to treatment options. So back to Dr. Deng, how do you treat skin cancer?
Yeah. So the good news is, especially when caught early, these are highly curable. So that is the one great thing about skin. Skin is readily available. We can see it, we can diagnose it early, and we can have great outcomes for patients. In the really, really early stages of, again, I'm not talking about melanomas right now, I'm just talking about general skin cancers. And if caught really early, we can sometimes treat them non-surgically. So for example, we can sometimes treat little precancerous lesions with liquid nitrogen by freezing them, or with topical creams that can, kind of peel, quote unquote, the top layer of skin. So those are kind of non-surgical treatments. But for those are pretty much mostly for the kind of early stage when caught early. And then if someone does need more surgical treatment, especially for basal cells and squamous cells, we can offer things like excisional surgery. So that's where we remove the lesion with a little bit of surrounding skin to make sure that all the cancerous cells are out. And then we also have a more specialized form of surgery called Mohs micrographic surgery, which is a more kind of precise, microscopically oriented way of performing surgery. And this is really ideal for skin cancers that are in really cosmetically and functionally sensitive sites, especially on the face, around the eyes, nose, ears, lips, on the hands, genitalia. So these are really critical anatomic sites where on the one hand, you want to make sure you get all the cancerous cells out. On the other hand, you want to preserve as much normal, healthy skin as possible. And so having that microscopically guided way of performing surgery and checking the skin for residual cancer while you're doing surgery allows you to be very, very tissue conservative. So in the early stages, really early, we can treat it non-surgically. And then even in the early stages for basal cell, squamous cell, and certain types of melanomas, we can offer more controlled margin evaluation with Mohs surgery.
Thank you very much, Dr. Deng. Dr. McCarron, how do you treat melanoma?
Patients are typically referred to me by a dermatologist with a biopsy-proven melanoma. So patients typically come to me when the resources of the operating room will be required to provide them adequate treatment of their diagnosis. So I would say surgery is the best treatment for early stage melanoma. So what is typically required, we base our treatments off of how deeply the melanoma grows into the skin. And that's commonly referred to as depth of invasion. So when I'm looking at a pathology report for one of my newly diagnosed melanoma patients, I think of it as kind of like thin, intermediate, and thick. So a thin melanoma would be a very early stage melanoma, and a thick melanoma would be a later stage. Intermediate, of course, would be in between. And again, this is kind of like depth of invasion measured in millimeters. So if we're dealing with one of our thin melanomas, I mean, that would typically just require something that we refer to as a wide excision. So I take about in the doctor world, we talk in terms of centimeters, but for the patients listening, I would say that you take about 1/4 of an inch of normal skin around the biopsy site. And then that would be considered an adequate treatment of the melanoma. And some of my patients are, they'll say, hey, doctor, on my pathology report, I noticed the margin is clear. And I kind of have to reiterate to them that that was a diagnostic procedure, and what we're going to perform is a therapeutic procedure. And so they still require the additional wide excision with the 1 centimeter or 1/4 inch margin. And when we do that excision, we do excise a full thickness of the skin. Now, as the diagnosis is delayed or the thickness of the melanoma increases, then we offer patients something called sentinel lymph node biopsy. And I always say to my patients, the sentinel is like the guard lymph node. That's the lymph node that's going to grab a melanoma cell if it's trying to leave the skin and go somewhere else. And that's kind of being put in more simple terms. I mean, really, it's what is the biology of the melanoma and does it have potential to spread? And if the sentinel node is positive, that would give a good indication that the melanoma developed the ability to spread somewhere else. So in those cases, it gets a little more complicated. The patient comes to the hospital earlier in the morning for something called a lymphatic mapping procedure, where a tracer will be injected around the biopsy site. And then the patients will lay under a big camera and we'll see where that melanoma would travel to if it did. And I always have to reiterate to my patients, the fact that the lymph node lit up or the fact that the lymphatic mapping identified a node does not mean positive. It just means that's the one that we remove to determine if it indeed did spread. So that's another operation that would be, required. So think of it in terms of thinner melanomas, get a wide excision, intermediate thickness melanomas, get a wide excision and a sentinel lymph node biopsy. And then our thicker melanomas, that requires something a bit different. And I'm sure Dr. Gibney will kind of comment on some of those issues. They require additional staging procedures. Many times if I'm dealing with a thicker melanoma patient, and that means over 4 millimeters in depth or ulcerated, sometimes those patients will even require treatment before I operate on them, especially the patients that when I examine them, I actually feel a lymph node. So, so really my role in the treatment of these patients is to surgically remove the melanomas. And again, these are usually done as outpatient procedures and the patients tolerate them very well. Rarely we do have to do skin grafting or skin flaps. If the complexity of that goes up, we have a terrific plastic surgery team that we work with, and they help us out quite a bit. And so I would say at the present time, surgery is still the best way to treat a melanoma and basically, quote unquote, cure an early stage melanoma.
That's good news to hear. So speaking of the surgical options for treatment, you mentioned that your patients can often go home the same day. So I imagine they're minimally invasive options that are available. Correct, Dr. McCarron?
Of course. And so I would say that melanoma surgery, like I said, it can be very straightforward. I mean, it's basically a skin excision. Ways to kind of reduce, we would say reduce the morbidity or reduce the impact on the patients would be if we could do smaller excisions. And like Dr. Deng mentioned, the use of her ability to do Mohs micrographic surgery is kind of along that minimally invasive realm of doing skin surgery where she can reduce the margins. And even on non-melanoma skin cancers like basal cell carcinoma or squamous cell carcinoma, Dr. Deng's probably, I'm sure she's able to do a wonderful job on the central face and minimize scarring in sensitive areas.
Very good information. Thank you, Dr. McCarron. Also along those lines, do you treat advanced stage patients differently than earlier stages for melanoma and skin cancer?
Right. So again, if you have a patient sent to you with a later stage or a more advanced stage, things definitely get a bit more complicated for the patients. And what I mean by that is that not only do they have disease in their skin, but they may also have disease in a regional lymph node. And then many times in higher stage patients, we will do something called a PET CT scan or imaging of their chest, abdomen, and pelvis with a CT scan. And if the melanoma has spread outside of a regional lymph node, we would consider that more along the lines of a metastatic melanoma. And in metastatic melanoma, those patients require systemic therapies that would be provided by medical oncology or Dr. Gibney. I can tell you my approach, just to bring it back to patients who have regional disease or palpable lymph nodes. I really strongly advise those patients to have a few doses of immunotherapy, which can prime their immune systems to kill melanoma cells. And then after the initial doses of the immunotherapy, then we can go back and render them free of disease. After the operation and they're clear of their melanoma, then they would typically go on for additional immunotherapy for approximately a year. But again, Dr. Gibney will be able to comment on that much more readily than I.
Well, thank you very much, Dr. McCarron. Perfect segue to Dr. Gibney. Could you talk about what other treatment options are available for melanoma and skin cancer?
Sure. So I think Dr. Deng and Dr. McCarron outlined the management of the early stage patients. And there is a certain point where the risk of recurrence is high enough that the care then gets integrated with medical oncology. And things are a little bit more complicated, as Dr. McCarron was stating, where surgery is not the only treatment modality that we like to offer patients. When the melanoma is a bit more aggressive and the depth gets into that intermediate or thick depth that Dr. McCarron was alluding to, that's typically when it's over 2 millimeters deep. We know the recurrence risk, even after the right surgery, can be as high as 35%, 40%. And it doesn't mean that the surgery was done inappropriately. We just know that, unfortunately, the cancer cells can spread outside of the surgical area before surgery and might show up in a year or a few years down the road. And what we try to do is to gauge the risk of patients for recurrence when they're being considered for surgery. And patients who have palpable lymph nodes, as Dr. McCarron was alluding to, are at even higher risk. And there's been a number of clinical trials trying to address this risk and how we can lower the risk of recurrence. We fortunately now have access to very effective therapies. And the more common therapy that we use is called immunotherapy. These immunotherapies are typically intravenous infusions. They're proteins that are infused every few weeks. They stimulate the body's immune system, the white cells, the white blood cells, to become more active and go after hiding melanoma and tumor cells. And by doing that, you can effectively clear the tumor and prevent recurrences in many patients. We've now seen that giving immunotherapy after surgery in high-risk melanoma patients, it reduces the recurrence risk by about 40%. So that's a year of treatment, and hopefully will be very beneficial for patients in that what we call adjuvant setting after surgery to prevent the recurrence. Patients are exposed to potential risks when we do offer them these types of therapies. So in some cases, there's concerns about the risk versus benefit balance. The risk of immunotherapy is very manageable. There are about 15 to 20% of patients that will have more serious side effects where the immune system can cause inflammation in healthy parts of the body. But the vast majority of these side effects are treatable, manageable, reversible. There are some that can be more long-lasting, where patients require hormone replacement if there's inflammation in the endocrine system. But the vast majority of patients fully recover back to their baseline and go on with their lives. The very exciting area that Dr. McCarron was alluding to is what we call the neoadjuvant space, where we give drug therapy before surgery. And we still use the same drugs. It's just giving a little bit of the drug beforehand and then after, as opposed to just giving it all after surgery. And there are some potential logistical benefits for this. We typically can get patients started on the immunotherapy early in the setting, while the surgical plans are taking place and the scheduling. We also think that getting drug therapy started early and not late gives us a head start, that we're treating the disease and preventing it hopefully from spreading further And by the time they get to the surgery, there may also already be a treatment response that can be observed. The patients usually go through a couple months of treatment, 1 to 2 months, and then go on to surgery with this immunotherapy strategy. And if we do see that there is a response against the tumor, the data has indicated that those patients have very favorable outcomes. So it's a very helpful piece of information for us to have after the patients go through surgery and we are reviewing the results. The larger benefit, though, the study that we reference most often is a study called SWOG 1801. And in that study, it actually showed an improvement in survival, less events for patients if we give some of the drug before and after as opposed to just afterwards. So we do think that the long-term outcomes are actually improved in that setting. So this is a very exciting area that we work very closely with our surgeons to coordinate the care and to determine where it may be the most appropriate.
Thank you very much, Dr. Gibney. So speaking of those treatments, are there any side effects that patients should be aware of?
So there are some side effects that can happen with immunotherapy. We do see that with single agent immunotherapy agent regimens, about 20% of patients will have a serious side effect. The more common side effects are inflammation in organ systems like the bowels, the skin, the liver. So these can be forms of rash, diarrhea, or on blood tests, your liver blood work can be elevated. Those are monitored during treatment. The vast majority of these side effects are reversible. We hold the immunotherapy, we give steroids in more severe cases, and that side effect does go away over a period of a few weeks usually. Some cases might be a little more challenging that require longer durations of treatment, typically with steroids or other immune modulating agents. And there are rare cases of longer lasting side effects, but I would say the average experience a patient goes through is good, that even if they do have these serious side effects, they're very manageable, they recover very quickly, and then they get back to their normal lives. The other part I did want to bring up is that we do have other treatment options to prevent recurrence besides just immunotherapy. So in patients where their tumor harbors a genetic alteration or mutation in the gene called BRAF, there is the option for targeted therapy. These are pills that patients take on a daily basis. We have approval for use of the 2 drugs called dabrafenib, trametinib as pills that they would take on a daily basis for 1 year total. Those also reduce the recurrence risk by around 40% and are an effective option alternative to immunotherapy. So there are differences in side effects that can be seen with those. There's different route of administration. Sometimes patients have other medical issues where it may favor using one type of therapy versus the other. So we are fortunate now that we have 2 different classes of therapy to offer to our patients who are undergoing surgery to prevent recurrence and to improve the outcomes. Now, the discussion for stage 4 disease, as Dr. McCarron was starting off, is a little bit more expansive. We have slightly different treatment approaches in patients that have distant metastasis if the cancer is spread to an organ like the lung or liver. And the risk of side effects are similar, but when we're in that scenario, we tend to use more aggressive strategies. So the risk to patients in those scenarios are a little bit different.
Thanks for explaining that, Dr. Gibney. I'm just curious, that sparked a question about life expectancy. So I imagine this answer is going to vary depending on the stage of cancer that the patient has, but what's the life expectancy for someone with skin cancer versus melanoma?
So Dr. Deng did a great job talking about the differences between basal cell carcinoma and squamous cell carcinoma as opposed to melanoma. Most of those cases, when the patient undergoes surgery for basal cell and squamous cell, those patients are cured. We shouldn't see a recurrence in the vast majority of those cases. Unfortunately, with melanoma, the risk of recurrence is much higher. And then that becomes a potentially life-threatening situation for patients. Now, there are scenarios where basal cell carcinoma squamous cell carcinoma and some of the other rare skin cancers can spread, can lead to potential life-threatening situations. And we do have to treat those patients with systemic therapy, drug therapy as well. But melanoma overall tends to have a higher risk for patients. When we look at the risk for melanoma in particular, we talk about risk of recurrence when the patient's being considered for surgery. So if a patient is stage 2, the risk of recurrence can range from 20% all the way up to 40%. A patient that has stage 3 disease, the risk of recurrence can range from anywhere from around 30% all the way up to 60, 70%. So once a patient though recurs and it's not a situation that we can consider surgery, then we start thinking about things a little differently. We're hopefully going to put a patient in remission and create a long-term survivor and be able to come off treatment. For stage 4 melanoma, before we had the advent of the new drugs, the long-term survival rate was actually quite low. That used to be around 10%. If you go back to the 80s, 90s, early 2000s. Around 2010 was the first approval for some of the newer immunotherapies and then subsequently the BRAF targeted therapy. So in the last 10 years, we've seen much more effective therapies become available for patients, and the expected survival of patients, the prognosis has dramatically changed. We know that stage 4 disease is potentially life-threatening and lethal, but we've seen the survival of patients long-term shift from around 10% to 50% or higher in some cases with these new immunotherapy and targeted therapy options.
That's reassuring. That's good news, Dr. Gibney. Thank you very much for explaining that. Right now, I want to direct to Dr. McCarron. So if someone is diagnosed with skin cancer, should they get a second opinion? What do you recommend that they do next?
I think like Dr. Gibney has just expressed, there seems to be a whole range of risk associated with skin cancers. So again, the non-melanoma skin cancers like squamous cell carcinoma or basal cell carcinoma are very treatable. I don't know if a patient would necessarily need to seek a second opinion for those types of issues. Even early stage melanomas, many of the early stage melanomas treated in this region would be treated by dermatologists or even plastic surgeons. I think when you can take advantage of the group that's on this call right here is when you have more advanced stages of melanoma, like Dr. Gibney was describing. I mean, even the intermediate, I mean, I'm going to throw numbers out there, but even like stage 2B patients, they would likely benefit from a second opinion, because I think the group of people on this call are totally committed to treating melanoma patients. We have a melanoma working group. We have multidisciplinary tumor boards. I mean, we're familiar with basically every treatment that's available to the patient. And so I think anytime a patient is dealing with a complex issue, a second opinion is always beneficial. And you always want to seek out people that kind of do a lot of it. So high volume centers seem to produce the best outcomes, and it would definitely be worth the call or the visit.
Thank you very much. I have a few other questions before we wrap up. I'll address this to the entire panel, so feel free to jump in and respond. So my next question is about clinical trials. So are there any clinical trials available for melanoma and skin cancer?
So I can start us off here. That's a great question. And the answer is resoundingly yes. Of course, we are always trying to improve the field and do better for patients and really get better numbers for survivorship and being able to treat the cancer. And not only that, we're trying to help patients with less invasive surgery and really understand when we have to use more aggressive techniques, when we can get away with using less aggressive or less risky scenarios. So I think some of the examples that I would put out for trials that we have here at Georgetown, as well as across our MedStar system, including one of them is looking at the size of the surgical margins. So if a patient sees Dr. Deng and Dr. McCarron and they have melanoma, and the standard would be 2 centimeter margins, do they actually need it? Can that patient have actually a smaller excision and still have the same outcome? And there's now a clinical trial that we participate in that's looking at 1 centimeter versus 2 centimeter margins. We have trials trying to lower the risk of recurrence after surgery. So one of the examples we talked about was giving drug therapy after to lower the risk of recurrence. The standard approach in many cases is a single agent immunotherapy agent. For example, pembrolizumab or nivolumab. Recent data with addition of a personalized cancer vaccine, so a vaccine that's developed specific to that individual's melanoma tumor, has shown very promising data in a randomized phase 2 trial, lowering the risk of recurrence significantly beyond just the single agent immunotherapy agent. And now we're continuing to participate in that personalized cancer vaccine study in collaboration with the pharmaceutical companies Moderna and Merck. And this is something that we offer to our patients that have stage 3 disease and managed at MedStar. We also are looking to treat patients who fail to respond to the standard immunotherapy agents. So some of these agents, while great opportunities for patients to be put in deep response or even remission, not every patient responds. So with the current immunotherapy strategies, with immune checkpoint inhibitors, we see about half the patients do fantastic. But that means the other half, unfortunately, still is looking for other options or might succumb to their cancer if they can't find an effective option. And one of the newer developments has been T-cell therapy, where the patient's tumor is harvested and the T cells are extracted from that tumor, expanded in a laboratory, and are reinfused back into the patient as a therapy. There's been a recent FDA approval for one of these agents called lifileucel, and we've been working with the company in the clinical trials and development, as well as other companies with very similar therapies. And this is something we offer here at Georgetown now as clinical trials, and in the future, we are working towards offering a standard of care. And these are very exciting developments and hopefully really going to change the future for patients with melanoma.
Very good, very interesting, Dr. Gibney. Thank you very much for sharing all of the clinical trials that are going on. I'll also share this question with all of you. What are you most excited about in terms of the future of skin cancer and melanoma treatment?
I can certainly comment on that.
All right.
I'm very excited that we are now able to effectively treat our patients with less and less morbidity or less impact on the patient's body. Just like Dr. Gibney is saying, we're trying to reduce our margins of excision. You know, we'll likely go from 2 centimeters to 1 centimeter. I cannot really even remember the last time I did a radical lymph node dissection where we would remove all the lymph nodes in a region and render those patients with problems with their extremities and lymphedema. The fact that we have these effective targeted therapies and immunotherapies mean that I don't have to perform these huge operations on patients anymore. So that's extremely exciting for me. And then the other thing, when we talk about survival of patients, Dr. Gibney, you might be able to comment on this. I don't even think our survival curves have matured to really express the advances that have been made over the last 10 years. So we're going to see these survival curves start to mature and be even better and better. And I mean, I just can't wait to see the impact. And, you know, the real question is going to be when we're able to treat someone and the disease disappears, then Dr. Gibney is going to tell me I don't even have to do surgery.
I think you'll still have a job, Dr. McCarron. So.
Well, very thankful for that message. It's nice to know about the team approach that's available here at MedStar Health. It's great to know about clinical trials that are going on, the advancements in treatment that are available. Very good information. So before we wrap up today, I'd like to ask all of you, what's one takeaway that you'd like to share with our audience today? I'll start with Dr. Deng.
Sure, happy to. So I think the one message I would like to share, the takeaway is that skin cancer is highly treatable. It is easily detected. We can see the skin, we can't see the liver, we can't see the lungs, not quite the same way. And so if you notice something, early detection always it is always the best approach. We have fantastic, amazing treatments for people who need them with more advanced cancers, but I still think early diagnosis is key.
All right, Dr. Gibney.
So I agree with Dr. Deng that we still have a very important role of early diagnosis and early surgical management. We think that's where we have the best outcome for patients. If we can identify it early enough that when you remove it, it really had no chance to spread and become a life-threatening problem. But the good news is if it has spread, the developments are incredible that we've seen in the last decade and continue to see as the research field moves forward. And what I would express to people listening is that if you do have a more advanced case, a second opinion may be warranted. Learning about the new research opportunities to participate in the new developments. Here at MedStar, we really incorporate this into our discussions, our treatment plans, and certainly happy to be here to support patients either as the primary oncologist or even in a secondary role for a consultation.
Thank you. And Dr. McCarron.
I guess as a final word, I would say the easiest tumor to treat is the one that doesn't exist. So I just want to really encourage people to be sun smart, avoid those blistering sunburns, and avoid getting a skin cancer altogether. And then you wouldn't have to meet any of us.
Thank you very much, Dr. McCarron. That wraps up our broadcast for today. Thank you so much to all of you, our experts, Dr. Deng, Dr. Gibney, Dr. McCarron, for joining us today, sharing such important information for our viewers. Thanks to all of our viewers out there for tuning in as well. We really appreciate your time. To learn more or schedule an appointment with us, please visit our website at medstarhealth.org/cancer. All right, thanks again. Use your sunscreen and have a great day.
Thanks. Bye now.